Welcome to the Vitality Cast webinar, sponsored by the Vitality Depot. I'm Dan Davidson, your host. I am a chiropractor and field doctor, and I'm very excited about today's topic, the clinical effectiveness of spinal decompression. We're always learning about new therapies and treatment, and we're happy to have Dr. Brian Hawley today as our guest presenter. He's a successful clinician, businessman, and sought-after speaker. He is the owner and director of the Magna Chiropractic Clinics in Southern Kentucky. He's also a national advisor to several decompression table manufacturers, including the one he's going to be talking about today, the DOC compression table. He speaks at state boards, regularly travels across the country on decompression therapy, and he's used it in his practice for many years. He himself has logged over 7,500 individual decompression visits, so he has a lot of experience. Dr. Hawley, welcome to Vitality Cast webinar today. Dr. Hawley, it's all yours. Can you hear me?
I can hear you. Lost you for a quick second, but you
Okay,
came back
great.
on.
Okay,
All right,
wonderful.
that guy you introduced, it sounds like a heck of a guy. I'd like to meet him someday, I tell you.
Well, yeah, you sound like you have a lot of great experience, and I know you've got a lot of information to cover, so I'm going to let you get right into the heart of your presentation.
Very good. Thank you, Dr. Davidson. And doctors, thank you for attending. Like the doc said, we have a lot of information to cover, and I'm going to kind of blow through it pretty quick. So if you have some pens and papers, take some notes, and this should be recorded so you can archive it. Basically, I'd like to start off. We are in Southern Kentucky. This is a quick picture of our clinic. We're in actually a medical complex. We have 12 orthopedic surgeons and 2 neurosurgeons that we share patients with. We do a lot of co-treatment. My office is on the 2nd floor. We got a little under 5,000 square feet. This room here is where I hold a lot of my seminars. We have an MRI, DEXAs, X-rays. We have a pharmacy in our building. So a lot of the decompression stuff that we do, I hate to coin the term cutting edge, but I got to be honest with you, there's not protocols out there, and we're developing these protocols here because we see a lot of complicated cases, and I'm going to get into some of those with you here. The premise for this is for the doctors out there that are wanting to do decompression, that are looking at tables and devices that are wanting to implement in their clinic. This is going to give you some basic 101 stuff. The other premise is for doctors that have decompression and are looking for some updated information because there's not a lot of seminars or educational programs out there for decompression. So sit back, hang on, and we're going to kind of go through some of this, and I'm sure you're going to get a lot of good information. So without further ado, for this webinar, I want to make it very clear, traction, decompression, because there's so many lines drawn in the sand on this, I'm going to use those terms interchangeably. Basically, decompression is actually an event that will happen in time under ideal conditions of traction, okay? So bear with me if we go back and forth on decompression or traction. It's going to mean the same thing, okay, for the purpose of this webinar. Now, being in the field with you guys, I see patients on a regular basis. I have other doctors in my clinic that work for me, and this is the options when the patients come in with disc pathology that they have. I mean, they have nothing, and believe it or not doing nothing is a viable option. Unfortunately, a lot of people take that. They have the surgery, physical therapy, chiro massage, pain management, medicine, decompression. But, you know, of all these options, and there's probably many more, there's only 2 that will directly affect the disc. That's surgery and or decompression. So obviously we're going to be talking about decompression. Stems from traction, which, you know, if you've seen the movie Braveheart, you know it's been around for years. The styles of traction, basically 3 categories. You have your mechanical, gravitation, and manual. And we're going to hit more on the mechanical. You know, the gravitational is back in the 70s and 80s, the gravity boots hanging upside down, and the manual traction is, you know, a lot of the cervical traction manuals are the straps that we've seen some of us probably even use. But for the mechanical, a lot of the problems that we encountered early on in our years was trying to overcome the guardian reflex. You know, that we weren't designed to be pulled apart. So what happens is you start pulling on the spine, especially if you have a hot disc or some other pathology, the body's protective mechanism is going to kick in. You're going to elicit the Golgis, the spindle fibers, and you're going to start getting the guardian reflex. I'm dating myself here, but years ago when I worked in hospitals on med-surg, I would be the one that would put the overhead trapeze on the hospital beds and set them up with sandbags for a constant traction. You know, did we ever get disc, get down to the disc level? You know, honestly, maybe not, you know, because we had to really overcome the guardian reflex. But nowadays, the tables have gotten a lot more sophisticated, and Dr. Dyer, actually I know Alan and his son Larry very well. I've been to their house several times. I used to do a lot of consulting with them. He actually invented the first true decompression table. Actually, the VAX-D did back in '87. It hit the States, you know, due to all the red tape and FDA clearance and all the other stuff, the 510K clearance that the companies have to go through in '96. And what the tables look like was something like this. And actually, this was one of the first tables that I've learned on. The patient would lay. It was a basic table, split table design. We could only lay the patient prone. They held on the handles, and the motor head pulled them. And we had like a seismograph thing that would scratch on paper the muscle spasms and the poundages used. This was great. It helped a lot of people, and it was really successful. Now, the other thing, too, is after they were done with decompression, we treated them actually for shoulder problems. So it helped build our practice. But seriously, though, this was great for the groundbreaking, but it did, you know, you can imagine people with facet problems and other pathologies. Not everybody can lay prone. But what the success of this company was leading up to was the rise of table companies. Over the years, you know, a lot of you guys are out there. You've been through this as I have. Seen the ads. There's a lot of table designs at all prices from $8,000 up to $160,000. The problem was there was a lot of front-end sales, no back-end support. I call them dog and pony shows would emerge, and manufacturers giving, you know, to my colleagues, the manufacturers were giving coding advice, and a lot of it was erroneous, and they got in trouble with it. So you got to watch out for some of them out there. There is some good reputable ones, and with this came a number of designs. There is you probably recognize these. Actually putting this together, there was more tables than I could fit on the slide here. I'm going to classify first, second, and third generation. I have spine med tables. They're $120,000 new. I got 3 of them when I started years ago. I call these the split table design. They're first generation. You can only lay supine. Then they came out a second generation table where you have, and this is my drawing here, so bear with me for the lack of artistic design here, but the patient's head will go here. You'll have a harness system that will attach to a motor head. This here would be a straight motor head. This here is if you're going to do a lateral bending one. Why I call this a second generation is because you can actually change the angles a little bit, but the problem that I found with these tables is the table's still on rollers. It's still going to go, the lower part is going to go in one direction. Hence, if you want to pull a lateral bend, the head, you pop a pin and the head will swing to either side of the table, but you still have the table going in one direction, and you have another force vector pulling you in a separate direction. Physics, I didn't like that. The same thing with the big tower models. They had the patient's head would go up at the top and their feet would go down here with a harness with a cable going to a pulley system that would raise or lower depending on the angle of disc. Yet again, the table would go in one direction while you're pulling, have a force vector going in another. Later on, we started trying to figure out how we can eliminate those, and we started looking at the flexion distraction tables. Now, I've done F&D in my clinic for years, as most of you have. I love the aspect that the table can do multi-directional, and you have single force vectors pulling in one plane. And you can also do rotation. Finally, we came up with what I call a third generation table, the DOC. I found this, and now we have them in our clinics. It's basically, the beauty of this, it's a flexion distraction table that does decompression. So I can take and go, you know, up or down for flexion or extension, depending on the pathology. I can also go left and right and axial rotate, and you can also have the patient lay supine or prone, and it does lumbar and cervical. And I'm going to get into a little bit of details why having these multi-angles is important. as clinicians, we're familiar with a lot of these diagrams here, but what I use in my clinic, I found being able to do a mirror image decompression is huge importance to the patient. For example, severe facet arthrosis, we can actually lay the patient either supine or prone, depending on the pathology, and we can actually laterally flex and open the non-involved side and even axial rotate to create a space while we do decompression. A lateral disc herniation, we could do a mirror image. We can actually open the wedge by laterally flexing. A laminectomy or a hemilaminectomy, we could favor the non-involved side. A lot of times I'll get some pelvic torsion coming in, and this is a normal pelvic, but a pelvic torsion might be this side of the ilium would be actually tilted forward, causing a rotation on the spine. We could actually axial rotate and derotate that spine, taking pressure off the muscles while we're doing decompression. Now, clinical pearl, obviously, another thing to look at, if you have a case like this, you have an anterior pelvis on one side, you want to look at their feet, you want to look at pes planus, flat foot, and start working the kinetic chain. The other thing that we're playing with right now is our scoliosis patients. Now, I want to be clear, decompression won't fix a scoliosis, but in the lumbar, just like on this x-ray here, that patient's got some disc problems. If they're having a disc herniation, we can most definitely deal with the disc problems with decompression, but what we can do, like CBP, doing their mirror image adjusting, we're a scoliosis clinic as well. We can do mirror image decompression, which is huge for our scoliosis patients. Now, how do I know which ones are good patients or not? We're going to kind of go through a quick exam what we do. I do a lot of these exams from my ER days. I was the code team leader, and I used to have to triage a lot of the patients, and I've adopted it to what we do here. A lot of the times you're going to ask where they come from. Just think of your existing patient base. You can do direct or indirect marketing. We get 90% of our new patients from direct doctor referrals, MD referrals, and some of the walk-ins. I can advise you guys, if you don't have a prescription pad for your clinic, get one. If you need to, email me, and I'll fax you or email you a copy of ours. Huge practice builder. When I'm looking at patients, the 4 criteria I look over is, number 1, medical, obviously, medical necessity. They have to have some form of disc or facet pathology. They have to comply with my protocols. They also have to have a psychological commitment and some form of ability to pay. Now, what I mean by the ability to comply with the protocols, I'm not going to do decompression on a patient 1 time a week. Years ago, I had airline pilots, truck drivers that were only in town for 2 times a week. I tried it, and I got to be honest with you, the results weren't there. As soon as I bumped to a minimal of 3, the results exponentially skyrocketed. And we're all colleagues here, so I'm not going to try to give you false information. I don't know why that works. All I know is it just does. Going from 2 visits, you don't get the results. 3 visits, you get the results. So they got to at least come in 3 times. Psychological, some people are just hell-bent on having surgery. They have the poor me syndrome. They're downers. They're a suppressive personality. They don't want to do this, and they're not going to get better. You have to have the ones that are wanting to commit to this. And we do have different payment plans available. We do insurance, cash, especially in the economy. You have to be able to work with the patients, and they have to have some ability to pay. Now, the other thing I got to look at when I'm identifying these is I look at the nature of the pathology. Is it chemical or mechanical? Compressive movement disorder or disc or nerve root, okay? How do I identify these? We're going to talk about the physical exam. I always watch them walk into my office, into my examination room. If I miss them, if my tech puts them in first, then I have the patient go out and I walk them down the hallway. I'm always walking their intelligent posture. Kind of gives you, and I have some of the definitions of the disc migration that you'll have, textbook with the migrations. I always do a range of motion, and I document. Reason being is I'm trying to make as many subjectives objective as I can. We are big sticklers on documentation and paperwork in my office. And, if decompression is so successful at getting the patient out of pain quick, if you have them down for 15, 20, 25, 30 visits, and on visit 6 they're out of pain, but yet you still have a whole treatment thing to go, you have to have something else to go by other than a pain scale, so hence the range of motion. And we do a re-eval every 12th visit or 30 days, whichever comes first. That's according to AMA standards. I also do a basic standing chems test. You're going to find with a lot of the chronic disc pathology, you're going to have facet syndromes. Now, I also do a FARFANS. Basically, it's a lazy man's Kemp, I call it. Basically, what you're doing is you're actually anchoring the spine, as the doctor is showing here, and you're torsioning the pelvis. This takes the pelvic stabilizers and lumbar stabilized muscles out of the picture because you're off of gravity here, and you're getting true facet motion here. The other thing we do, the typical SLRs. One of the things, I did a seminar, and we had a couple of the insurance executives in my audience. They came up afterwards and they said, you'd be surprised the number of doctors that do SLRs. I said, well, yeah, it's standard textbook. They said, you'd also be surprised the number of doctors that just says, yes, SLR positive, left side or bilateral. They said, what we want to see is SLR positive, left or right, bilateral, at X amount degrees. So doctors, if you're doing these in your clinic, hats off to you, but make sure you're putting the degrees that you get in the positive findings. That was one of the sticklers from the insurance companies that they didn't see in the. We do some braggarts. Now, I always do this on the uninvolved side first, okay? The other thing I do in McKenzie protocol, this is from my old physical therapy days. We did a lot of McKenzie work. And if the disc still it's not a true desiccated disc, meaning the water is totally gone. If there's still some fluidity in the disc, you can have a migration pattern. And what we're going to talk about is a little bit about these, because that's going to tell you how to put them on the table. So basically, if a patient is they're flexing, and that produces no pain. The pain that was going down their legs, if it radiates or centralizes when they flex, that's a positive sign. So it's a flexion disorder. So what I would do then is put the patient on the table supine, because any supine position, you're going to have a flexion component involved with it, and it's going to help the disc migrate back to the center. The other one, just the opposite. If a patient extends, they get better. It centralizes, and they have no pain. I would have that patient lay on the table prone. Now, when you're performing the extension, keep this in mind. The first 5 or 10 degrees of extension, when they're standing in your exam room, first 5 or 10 degrees will do a compressive force on the disc, okay? So that you're going to get more disc involvement. Beyond the 10 degrees, 10 to 20, you're going to start getting into facet articulations. What does this mean? So if you're getting a pain in the very beginning, first few degrees of movement, more than likely you're looking at a disc. If it doesn't come on until later in the degrees, say 20, 25 degrees, then you're probably going to be looking at more facet involvement. Just another clinical pearl, what we look for. Now, everyone's always asking me, pull patterns. Years ago, guys, we didn't have these. And the manufacturers are starting to listen to us doctors, and they're teaming up with some of them, and we're coming out with some pretty good designs. Pull patterns, what are they used for? They're used to identify different pathology for acute, for not acute, for facet. Different patterns can be plugged into the table for different conditions. Now, what is a pattern? Basic description of any pull pattern would be you'd have a pretension. This is when the patient's on the table. You have the harness on them. It's a pretension. Then you set a weight, and the table will start distracting out. And it's going to be your progression phase. Once you get to that prescribed weight, say it be 30 pounds, 45 pounds, then it will hold. That is your traction, and somewhere in between here that's where the magic occurs. That's where the decompression of the disc will occur. Then they'll go for your treatment cycle. Then at the end will be the regression phase. Now, in between, a lot happens. I'm going to tell you a little bit more about it. The progression stage, what I look for in a table that will have multiple steps, either pre-programmed or ones that I can program in. Why this is important is because if you have a hot low back, a disc that's really inflamed, you don't want to have a quick progression because the muscle won't adapt. It'll start firing against you and guarding. So you want to have the ability to have a slow ramp up or have ability to put in steps. So in other words, a slower ramp up or ones with longer hold times in the middle there would be for the acute. The more chronic ones, you could have a quicker ramp up and less of a hold time. Static traction is another program which is great because I use those in our clinic for a recent re-exacerbation will lower the poundage. So if we're doing an intermittent pull on Mary, and she goes out and rakes leaves one night, the next day she comes in, she hurt herself, I'll probably drop the poundage by 5 or 10 pounds and do a couple of visits with just static. Then I'll go right back to her intermittent. The other thing I use the static for is to have a chronic myospasm that will not release at all. So what we do is we hold the muscle and it'll fatigue over time, and then you can progress into the different patterns. Intermittent pattern, this is what we use quite a bit. Again, the same principle. Longer ramp-up times with longer hold times would be for the more chronic ones, or the more acute, excuse me. The shorter ramp-ups and shorter hold times would be for the more chronic ones. Muscle spasms, a lot of times on a custom program, if a table has that capability, you can program, instead of dropping all the way down from a peak force, you can put a little stair step. Lets the muscle adapt to the new surroundings so you won't get a recoil, and you can do this throughout the program. Again, having a table that can do this, either pre-programmed or customized, is a key, and it's going to make your clinic treating ability a lot more manageable. There's also, I call this a comb pattern because that's what it reminds me of. Think of, whenever you have these in your tables, think of a flexion distraction, a pumping mechanism. This works great with mild facet syndromes or mild disc problems, and you're trying to do some fluid exchange here. Same principle again, longer hold times, slower ramp-ups for more acute, shorter and quicker for more chronic. The regression phase, make sure that you have this down pat. Years ago, we didn't even know about this phase. We didn't have them on our tables. The patient would do good, then when the treatment was over, the table's going back, they were getting muscle spasms. Then we decided to put a regression phase in, and all it is just a stair step. It gets the patient back to their neutral position by stepping down, lets the muscles adapt. Now, this is my key to talk about imaging. Everyone asks me, do I need x-rays? In my clinic, here's what we've done for the years. I always get a plain film. Basically, if the patient has films that are 6 months or newer, I use those. However, by using sound clinical judgment, if a patient says, Doc, 3 months ago I had the films taken, great. I'll ask him, have your symptoms changed? Well, yeah, now it's going down my legs. Guess what? We're getting new films. Okay? So it's up to you, but that's my rule of thumb. MRI, I don't get them on everybody, but if someone has pain going down there, if they have positive disc signs on a plain film, you see the vertebrae, for lack of a better term, is pancaked out. You have a very narrow opening, and they have pain going down past the glutes. That's when I order an MRI. With contrast is for post-surgeries. Without is for non, just to give you a clue. And always talk to your MRI center that you're going to be ordering this from for their regulations. Basically, the MRI, I'm not going to get into reading this. This is what we're looking for. The white is normal. This is disc desiccation. The water is gone. We're looking for the bulge out in the canal. Just another view. The red line is going to show the cross-section. We have an HMP right out here going into the central canal. DEXA, do I get those? Yeah, if all indications that they might have some osteoporotic problems, yeah. Just to refresh, 1 to positive is normal, to negative 2.5, osteopenia 2.5 and lower, osteoporosis. Now, some of you in the audience are probably smarter than me. These are just numbers. So I went and asked the MRI center, you know, what does this mean? Break it down to a percentage. My MRI center told me that if they have a negative 2.5 or greater, that's equal to about a 40 to 43% bone loss. Okay, just keep that in mind. So decompression, I don't put anybody on if it's negative 2.5 or more. Okay. New protocol. I developed this years ago. I didn't like the 5 times a week 20 visit for everybody. The other thing is I don't like waiting until at the end of the cycles to do rehab. So what I do, I get them on various cycles. I do different stages. This is my visit protocol depending on the disc pathology that's involved, from a basic facet to a mild cervical, all the way to a post-surgery one or a very elderly one that we do. And we start introducing rehab right off the bat as well. What kind of rehab? I break it up into a couple different kinds. Passive rehab is basically what I call stretching and getting range of motion back, okay? I'll do this for the first week or 2 weeks, depending on the patient. I also incorporate stretching, PNF, and ART. on every patient that we do. Passive rehab, I also do the isometrics. We don't do a lot of resistance training in the very beginning. Isometrics, we're also doing a lot of research with this with our scoliosis patients. The isometrics will affect the posture muscles, and we're getting a lot of scoliosis changes by doing isometrics, and that's another webinar, but this is the order that we start our rehab in. The active rehab, we keep it low tech. We do synergy, therabands, physio balls. How do I know when to progress to active, which is basically resistive? When a patient when I see an increase in range of motion without an increase in pain, that's my clue when I start resistive exercise on these people while they're doing decompression. And we also do myofascial release all the way through. That's key. What types? Again, therabands. We sell these to our patients. Vitality Depot, they supply a lot of our products. It's a great rehab tool for the patients and a great reseller for you as a clinic. When the other phase is functional rehab. We do a lot of combo of the rehab that we do, meaning proprioceptive along with resistive training. And a lot of times we'll do things like, the vibration. We'll put a physio ball on a vibration plate or have them do a TheraBand with a physio ball. We also do balance and coordination with eyes open and eyes shut to work different tracks. Especially if you have a patient that has bilateral radiculopathy and you're doing decompression on them, their proprioceptive input's going to be thrown out of whack. It's key to rehab them doing proprioceptive. These are all billable. Again, that's another webinar. We're not going to get into the rehab codes, but we use neuromuscular education as the code when we build these. Now, taping, I got to be honest, we've started this about 1.5 years ago. Our patients love it. It does great for holding the patients in between their visits. We use the spider tape and the vitality tape. Again, with every patient that comes in for the first few weeks, we're going to be taping. We're going to send them home. Normally we tape on a Tuesday and Thursday, a couple times a week is what we do. Anyways, at this point here, I know I threw a lot at you guys, but there's so much and there's so exciting things you're going to be seeing by doing decompression therapy that one webinar is not going to encompass everything, but it's going to give you a general idea of how to use it and some of the things you can see. So at this point, I'm going to probably turn it over to Dr. Davidson, let him do some follow-up and tell you about some of the exciting products that he has to offer you guys.
Dr. Hawley, great presentation, a great overview of the history of decompression and traction, as you say. Just a couple follow-up questions. You mentioned the DOC table, which I think you may have a slide of also that we're going to tell people about, that you're able to do the lumbar and cervical. Can you maybe just address just briefly maybe some of the clinical protocols, some of the types of patients that you're helping?
Oh, absolutely. Absolutely. Here's what we'll do, and there's many scenarios that can portray into this, but a lot of times people will wait so long on getting what I call effective treatment on their low back that they'll start developing an antalgic posture, which will lead into cervical problems. So when they come in, by the time they come in to see you, you have what I call a double whammy. They have a low back and a cervical issue. My rule of thumb is I treat the worst scenario first. So clinically, if it's a cervical, fine. Clinically, if it's the low back, fine. I treat that first. So I'll treat the low back. At the end of the sessions, say if it's 15, 20, 25 visits, whatever have you may, I normally wait a week to 2 weeks in between because sometimes the antalgic postures goes back to normal and the neck will clear up on its own. If not, we start them right back on the cervical. Years ago, I tried doing both of them in the same visits. In my opinion, it was too much too soon, especially an elderly sedentary person. We're exacerbating the symptoms, creating an inflammatory response. So pick the worst case clinical and go with it.
Okay, that's good to know. Here's another question, a clinical question. Are these types of tables helpful for just general degenerative disc conditions as well as, maybe you can address that.
Yeah, what I love to do is just get them when they're just starting the degeneration process because it's so much easier to help the disc heal itself. So yeah, if you can get them with just general disc degeneration, that's the perfect time to get them. Once they get out, in my clinical videos, not in this webinar, I didn't go over them, but herniations, bulging, protrusion, and extruded discs respond great. The sequestered disc, I always get a consult from an ortho or neuro or their family doctor. So yeah, they respond very good. Protruded disc, I have done, the biggest one I have done was up to a 19 millimeter protrusion, and the guy got some great results on it.
Awesome. As far as kind of Monday morning implementation, uh, let's say you get this great new table, and there's a lot of patients you can help. Uh, you know, what about staff training? How long does each session take? Just talk about some practicalities of kind of that Monday morning implementation.
Call me first. No, but no, Monday morning, we schedule our patients every 30 minutes.
Okay.
That allows for about 5 to 10 minutes of setup, takeoff time, okay? What I normally do is the staff training, it's very simple. Again, with the DOC table in specific, you already have the pre-programmed patterns there. So depending on your state regulations, some states require the doctor to put the patient on the table and hit the go button. Other states, like in Kentucky, we will have the technicians put them on and set them up. I like to personally set everyone up the first time and walk them through the patient just to hold their hand.
Sure.
After that, they're fine. My techs do all of it for me. And as I said, you have that capability with the higher end tables.
Okay, and can you address a little bit more about the DOC table? And I think you have a slide that shows the table again. If you find that in your PowerPoint, just a little bit more about the pre-programmed options. I mean that sounds great. It's nice to not have to reinvent the wheel, right?
Well, absolutely. With the DOC, the screen, I wish I had one on the screen on this, because I could show you the actual screen of the DOC. Basically, they have 5 different pattern selections that you can go on.
Okay.
And again, it's basically from the static to the intermittent or the constant pull one. And it just goes from chronic to acute, depending on the pathology and the patient condition when you're starting them. And then they have another screen that you can go on, and you can actually customize those to your own. What we normally do, and here's one I didn't say that I'll recommend for Monday morning, I always have my doctors see the patient first, meaning we always do an adjustment. Now, for the disc patients, I don't do a side posture adjustment. I just don't want to run the risk of putting a torsion in there. I'll do a light flexion distraction on them or a pelvic drop. And if they're doing good, then I'll turn them over to my technicians in the decompression room, and then they'll go ahead and do the decompression. The other thing I'm always asked is, how do I know when to increase the weight? What I always do is I increase 3 to 5 pounds every other visit. And once I get to a certain weight, that patient's going to say, "Doc, I don't know what you did last visit, but my pain was gone." Well, all right, then I circle that weight in my chart, and we stop increasing. I'll hold them at that weight for a while, because that's their decompressive weight. Once they get there, and if they can hold that for a few visits, that's where I stay at their weight. I don't keep increasing. That's another clinical pro for you.
You're giving us a lot of pearls, which we appreciate. The doctors can learn more about the DOC compression table at vitalitytables.com. That's kind of a separate landing page where we have some more information. And just briefly, Dr. Hawley, in closing, as far as pricing of decompression tables, I know you mentioned they can go up to over $100,000. You had shared with me before the webinar that you really like the DOC table because as a kind of a third generation table, you're actually able to do more in a sense. There's more functionality at this table that's around $15,000 as compared to some of the earlier tables that did cost doctors over $100,000.
Oh, absolutely. Well, what's the old saying? Great taste, less filling, right? Has the best of both worlds. Yeah, I mean, I still have the other tables that I've had for years. Let's face it, I have 3 of them at $120,000. I'm not just going to throw them out. I still use them, but I have the DOC right in the middle of them, and I'm putting more patients on that, especially the ones with the more complicated disc pathologies, and I'm getting better results. at a tenth of the cost. So to be honest with you, I'm kind of jealous. I wish that this table was around years ago when I was buying these. I wouldn't have had the high lease payments that I did.
Right. And so to kind of follow up, if there's a doctor interested in adding this treatment to their clinic, I know you are available for the first 90 days as kind of a clinical consultant. Is that right?
Yeah, and when the manufacturer asked me if I'd be interested in that and help talk about their table, I said, yeah, but I need to be involved on the back end. The front end, that's fine, but what happens 2 weeks into it when the table's in the doctor's clinic? He has, not everything's going to be a vanilla low back. They may have a hemilaminectomy or a spondy that they're trying to treat. I think it's great to be able to pick up the phone and call somebody, or if you have 3 levels of disc herniations, be able to call and say, hey, can I fax the MRI report over to you? Would you look at it? We talk on the phone as 2 colleagues. I think that's huge. So, yeah, for 90 days, they basically get me and my other doctors in their back pocket to help them walk through cases.
That's tremendous value, and I know that you're also available kind of with possibly even a monthly consulting option, even to help doctors with marketing, coding. I mean, it sounds like it could be a very exciting thing to add to a practice, not only to help patients, but to boost your bottom line.
Well, it does, and again, it's all 2 scenarios. First of all, we're clinicians, so we got to be able to provide and care about the patient's care. But we're also nowadays becoming more businessmen. We got to. My surprise was that the decompression actually built my chiropractic practice. Because when they're done decompression, they're going to become a lifelong chiropractic patient. So, one feeds into the other. It's a great flow. The key is knowing where to put it in the flow to make it successful. And, after the 90 days, I've had a lot of doctors ask me, what do we need to do to keep doing this because they like it? So, I'm putting together some programs where I'm going to help them learn about marketing, coding, documentation, still doing the clinical. And the other thing is being able to manage. We have our clinic broken up into departments where I do statistical management, and we have our meetings each week in policy and procedures, and we monitor it. So, this is what I'm going to be helping the doctor set up for an ongoing basis.
Well, hey, again, we just want to thank you for the wonderful information, and I know that you've offered to do a few audio podcasts as well, that even where we can get in a little bit deeper into some of the clinical protocols, and we'll make that available to a lot of the Vitality doctors. And we talked about doing some other webinars. You had mentioned a couple other topics too, so you are definitely a clinical pearl, and we're glad that you were able to share with us today.
Well,
thank you, Dr. Hawley. And I'll mention Vitality Depot does have a special on the DOC compression tables right now, where you basically, if you buy it for the full amount or get qualified for leasing, you get $1,600 cash back, and you can use that any way you want, including you could consider that the first 5+ months of the lease that's already paid for. So it retails for $1,599, and then again the special is $1,600 cash back. So compared, as Dr. Hawley was saying, he had 3 tables and $120,000. This is about a tenth of what some of the tables used to cost. So it's a great time to consider this, adding your clinic, and you would have Dr. Hawley as a clinical consultant to get you started. And of course, we're here at Vitality Depot to help support you along the way with any tables or any other equipment, cold laser, whole body vibration, spider tech, tape, bracing, you name it. We're here to help. And as Dr. Hawley mentioned, we've got all the TheraBands and Synergy kits, so we can just help you along the way. So remember to visit vitalitytables.com and our website at thevitalitydepot.com. And the archives of this webinar and our future webinars are always at vitalitycast.com. Again, thank you, Dr. Hawley, for joining us today. And what's the simplest website that people can contact you now or in the future?
Yep, drbrianhawley.com.
And that's
And,
Bryan,
yep,
right?
HAWLEY.com. And I think at the very beginning when I have my clinic, they'll see this on the
Right.
archive. The slide with my clinic have my clinic web address and my personal consulting site web address.
That
In
is
case you wanted to go on and click on our clinic and see all that we offer here as well.
fantastic. And we will have this up on our archive probably by the end of the day. You can just go to vitalitycast.com to get this archive as well as some others that we've done in recent past. Thanks for attending, everyone. And again, Dr. Hawley, thank you so much for a great presentation today.
Thank you.
Okay, everyone have a great day and keep healthy. Bye for now.